The first thing I'll do is just ask you to tell me your name and your title.
I am Raywat Deonandan, Raywatdeonandan, epidemiologist and associate professor, Faculty of Health Sciences, University of Ottawa.
Okay, great. Thank you. You're used to that. I guess, first of all, let's talk about Ontario. Some pretty significant changes here when it comes to who and how they test and their isolation protocol. Let's talk about testing first. What do you think of this idea that asymptomatic or mild symptom people can't go and get a PCR test now?
Well, it's understandable. PCR capacity is overloaded. We haven't got a lot of testing capacity. The problem is in the isolation protocols and who has to isolate and for how long and how you get out of isolation. So my understanding is that symptomatic people are required to isolate for 5 days. That's based on an average number of days. The literature suggests that people are infectious. But some can be infectious for 3 days, some for 12 days or longer. So using an average is problematic, and it's unclear whether after those 5 days, if you're still symptomatic, whether you're free to go. Symptomatic people should not be so flagrant with their exposures if there isn't a negative test. So the concerning part is that we have people who are re-entering society with suspected infection and infectiousness without a negative test to clear them. I understand there are testing capacity issues, but this is where the rapid test can be used more strategically. Right now we use rapid tests somewhat randomly. People use them before their Christmas gatherings and things like that. They should be reserved to bring people out of quarantine and out of isolation. And so after a couple days of asymptomatic status, we should give people 1 or 2 rapid tests to clear them for reentry. Absent that strategy, I'm quite concerned that we're going to have infectious people wandering around assuming they're not infectious. So it is troubling.
And then the other question I had about this strategy that they're deploying, is the statistics-wise, the importance of gathering or having an understanding of how much infection is out there. Is that something that is important to have, or is that something that's a concern?
It's a concern. I don't see a way around it, though. The rapid tests aren't being captured by public health. It would be nice if there was a central registry where people could report their rapid test findings. It isn't going to be perfect, but we have other examples of self-reported data being used for surveillance purposes, like Flu Watch, for example. So that would be a simple fix, create a centralized database. Absent that kind of data, we're relying upon the test positivity rate of the PCR tests that are being performed to give us a sense of how deeply penetrating the disease is. And an absent understanding of case data, we won't really fully know how far along the wave we are and how much penetration the disease has into our communities. We're going to have to rely on the positivity rate and on the hospitalization rate to sort of make hand-waving arguments.
And then it seems to me, at least, the strategy here is obviously has to do with the capacity of testing, but also we're concentrating on the most vulnerable. So in particular, the 4th dose for those in long-term care. Is this a strategy? It seems like they've given up on getting a hold of transmission, community transmission here in the general population. At least that's my understanding. Is that a correct assessment, or?
I would hate to put words in their mouths, but that is my feeling as well. There seems to be an acceptance that transmission will be out of control for the next few weeks, and maybe there is a silent hope that unrestrained transmission might result in sufficient immunity in the population without much cost. I think that's a dangerous way of thinking, if indeed that is what they're thinking. I think we have to deploy more mitigation tools to slow transmission so we do not overwhelm the healthcare system. So what's missing from the announcement today was the mitigation tools that are being added to people's toolboxes. I understand the N95 masks are being sold to education workers, but not to students. They're not being sent to workers in other sectors. HEPA filters are being sent to school boards. They should be sent to people's homes. I'm concerned about the equity issues here. Low-income families can't afford N95 masks, rapid antigen tests purchased on the open market, or HEPA filters, and they're the ones least likely to be able to isolate at home if they get exposed and sick. we have to address the equity issues. And this is where governments can be heroic.
I want to briefly just talk about Quebec because they're taking a different approach. The premier speaking just now, and basically what's happening here. I'm actually in Montreal, so what's happening here is going back to restrictions. So it appears that they're going to put in a curfew. The private gatherings no longer allowed, only within a household. It appears their strategy is still attempting to limit transmission within general community as well as those most vulnerable. It's just interesting. I just wonder your thoughts, I suppose, on the two different approaches here that the provinces that are seeing similar comparisons when it comes to COVID that they're taking.
I think the difference comes about because Quebec is seeing code oranges. That's when they have a hospital code where they don't have enough staff because of COVID, and that's a crisis. So a code orange compels them to consider, well, if this happens very often in multiple clinical settings, they're in a really bad health system stead. And so slowing transmission there is intended, I think, to specifically target the stress on the healthcare system. Ontario isn't feeling it as much as Quebec is yet. And so the urgency to slow transmission is not yet being felt. I'm concerned that we will feel it here, and we may have to enact similar strategies as Quebec is now putting on the table.
So it's really I'm understanding here that Quebec is really just reacting to the fact that it's losing its healthcare workers left, right, and center.
That's my feeling.
In that case, wouldn't they? Go ahead, sorry.
No, that is my feeling as well. I think Quebec is feeling the healthcare crisis, the crunch, acutely, and they're reacting to that. Or they really are concerned about protecting their unvaccinated children, which we should be concerned about as well, and slowing transmission for that purpose. In any event, these strategies are quite different. And historically, whatever we see in Quebec tends to happen in Ontario. So we should watch that carefully for what might be our future a few days or weeks away.
One thing, an expert that I spoke to earlier, behavioral medicine, he told me that he felt that Quebec was lagging when it came to instituting more restrictions, and that this curfew and the latest ones were too late. If that's the case, is Ontario then a lot further back?
Look, the history of COVID, the short but brutal history of COVID these past 2 years, has shown us that the places that do COVID well have three things in common. Number one, they get really good at testing and case identification. Number two, they get good at monitoring their borders to not re-import infection. And number three, they act hard, they act early. And we tend to forget number three a lot. That's because of the insidious nature of exponential growth. By the time you see it, it's almost too late to act cautiously. So we're in a similar position now. We're seeing explosive exponential growth. If we want to curtail that growth, we have to act now and act hard. But the fact that we're not acting hard suggests to me that we're not interested in curtailing that growth, and maybe we have another goal in mind.
So just so you know, my report obviously is going to go over the changes in Ontario, the changes in Quebec, the differing approaches. And I've asked the questions I thought were pertinent to that. But do you think that there's something that maybe I am missing from that?
I think what's missing in all the analyses is always what do we do about the very large number of unvaccinated children who cannot be vaccinated? The perceived mildness of Omicron is due almost entirely to the fact that Omicron has a higher breakthrough infection rate. Therefore, it has a larger share of vaccinated people being affected, and vaccinated people tend to be hospitalized a lot less. Unvaccinated children don't have that advantage. So in Ontario, we have about 1 million people in that position. We have 700,000 kids under 5 and another 300,000 or so kids in higher age brackets who aren't vaccinated. So how do we protect them? That's the conversation I would like to see us have more openly and vigorously.
All right. Thank you so much for this. I appreciate it.
Thank you.